We are child development obsessed, business besties, and mums, and we're here to spill all our secrets.
We have a combined 30 years experience working with children, and each episode we will bring you up-to-date research and evidence-based strategies to set your children up to thrive.
I'm Lizzie Dawson, Australian exercise physiologist.
I'm Emily Mackey, Australian speech pathologist,
And this is the Move, Talk, Thrive podcast.
All right, welcome to another episode of the Move, Talk, Thrive podcast. It is just Emily here today. Lizzie is away today, but I am joined by an amazing guest. I today have with me Dr. Melissa Giglio. Have I said that right?
You did. That was beautiful.
Giglio, welcome to our podcast.
Thank you so much for having me. Very excited to be here.
Yeah, I'm excited to get into our conversation. But first, I'm just going to read a little bit of information about you so everybody knows who I'm speaking with today. So, Dr. Melissa or which one do you go by? Dr. Melissa or Dr.
By Dr. Melissa, because that's just easier for the kids and, it's a little less formal.
Lovely. Dr. Melissa was part of the founding team of clinicians at Central Health Partners Child Development Team in Hong Kong. She is a trained behavioural therapist with over 15 years of experience specialising in treatment of childhood disorders, including selective mutism, oppositional defiance disorder, ODD, attention deficit hyperactive disorder, ADHD, and autism spectrum disorders. She is currently the director of the Child Development Team, a multidisciplinary group of specialists offering speech and language therapy services, occupational therapy, learning enhancement therapy, and counselling. Dr. Melissa established the Confident Crew program, an intensive group behavioural therapy, the first of its kind in Asia. She has invited clinicians and patients from all over the world to participate and learn how to treat selective mutism effectively. Her passion for helping children with anxiety has led to explore alternative treatments and resources available to teachers and caregivers. Dr. Melissa received her doctorate in clinical psychology from, is it Rutgers or Rutgers?
Rutgers, yep.
Yeah, the State University of New Jersey. She earned her master's degree in clinical psychology at the New School in 2003, and her professional affiliations include membership in the American Psychological Association and the Anxiety and Depression Association of America, Selective Mutism Association, and Association of Behavior and Cognitive Therapies, and PCIT International. Yep. Dr. Melissa has presented at multiple international conferences, has written and been featured in magazine and newspaper articles, and invited on multiple podcasts. In 2022, Dr. Melissa co-authored a children's book about selective mutism and anxiety called Bravery Grows with her colleague, Daisy Geddes. Mm-hmm. Together, they are committed to providing resources to family without access to selective mutism specialists. Dr. Melissa also sits on the executive committees for the Zubin Foundation and Focus Hong Kong, and non-for-profit organizations in Hong Kong. So without further ado, let's get our conversation started. I have a few questions from just reading your bio, actually. So how does an American end up in Hong Kong is my first question. And what did your career look like, I guess, to sort of sum it a bit?
Good question. So it was just one of those things where my husband and I were newly married, and it was an opportunity that came up, and we loved the idea of going abroad. We weren't really particular about where, and I'd finished my doctorate. I was a postdoc, and when you're in the phase of life where you're just like wanting to start a family, and New York, is a wonderful place, but it's kind of a grind. So the idea of something new was fantastic, and I'd never been to Hong Kong. I ended up moving here. By the time we got here, I was 8 months pregnant with our first, and how I ended up with the clinic too is I just used this practice right when I had my son, and just the feeling of the medical practice, actually, not even the CDT yet. I was like, this is where I want to work because it's a very female focused, family centered practice that's all about you can be a working mom and you can also be a professional, and they valued that, and that was just an environment I wanted to be in. So it's been absolutely fantastic to be in Hong Kong and to be given the opportunity to create this clinic here where I get to bring my expertise and training from the States to Asia, where they didn't have professionals who did what I do. So I've been able to train lots of different professionals and work with tons of families and international families too, which is really nice too, to, really help as many people as possible.
Yeah, and obviously being on social media and online, your work spans across the world. It doesn't really matter what country you live in or where you're from. You can really teach anyone, can't you?
Yep, now we can, but back, I mean, this was like 13 years ago at this point.
Mm.
So like, I feel like we weren't using social media the same way professionally.
Yeah.
But I think COVID really helped us realize that, our reach doesn't have to just be in person. Like we can extend it and really train the people who are at the forefront, which is the families, in how to do this, and the educators. And I think that's really pivoted kind of our role and how we support people.
It's the same for us too. Like parents would have not really been open to the idea of doing telehealth sessions. And then that's one of the beauties or the benefits post-COVID is that it has really changed and opened up service delivery. And it means that, children that might not necessarily be close in physical proximity to a service can still access services or access resources. And there's so much more information out there now for parents where there previously wasn't, right?
Yeah, absolutely. I think that that's one of the positives that came out of it. There were so many things that it impacted, but that was a
Yes.
big positive where I think we got to shift the lens about how we traditionally did things. And I think to help us as professionals get more creative with how we could effectively teach parents how to do the work more than just leaving it to us to be the interventionist.
Yeah, I agree. And so you've got your children, do you? Did you say?
I have 3 now. So I came here with 1 on the way and I have 3.
And how
Yeah.
old are they? Are they in the younger years or the older years?
So they're 12, 10, and 8. So pretty spread out. Yep. So we're just getting through the lower primary, getting to the kind of upper primary years now.
Yeah, that's so lovely. I guess our children are our biggest teachers, I find.
Absolutely.
Even as clinicians as well, they're always teaching us how we can do things. And I guess working in Hong Kong in Asia, like you said, you've sort of developed new programs. Is it something that has taken a lot of education to get happening in Asia? Have people been open to accessing services or therapy, or what kind of barriers has there been with working, I guess, in an Asian country?
Good question. So since it's really international here, I feel like that was the first kind of cohort that kind of were drawn to the clinic, but really it's extended more to the local community at this point when they're looking for resources, they're looking for someone who has experience in this. And the good thing about Hong Kong is people really put their kids kind of in preschool at an earlier age. So by 3, most kids are going unaccompanied to something. And so we're catching these kids earlier than in the US. You don't necessarily have to put your kids in preschool. They could start kindergarten at 6 and maybe they haven't been in those social situations where this is something that's almost an expectation and it's every day. So they can really see when their child is struggling at an early age. So then we can actually intervene earlier, which means then we can really help them treat their symptoms and then change the course of their life, basically. So they no longer meet criteria. They are functioning like every other one in the classroom, and it's really just the best case scenario when we get kids when they're young.
Yeah, early intervention is key, right?
Absolutely.
Yeah, amazing. Well, leading into that, I guess, and leading into interventions and things. So, I mean, we first connected via social media because I can see, like on our video, I can see your lovely book in the background, Brave Free Grows, which I think I've posted a few posts about it. So people who follow me would have seen the book. You sent that across to me and we absolutely love it. Like as a family, it's one of our nighttime reads. And Evie looks like the little girl in the story, which she loves. But I first came across your work when I read that book and I thought this is a very well thought out book. This is it's like a very clinical book, but subtly, and it's a beautiful story for children. And it really demonstrates the practicalities of social anxiety, like and social talking, and sort of really down to earth book though for parents and children to read. So that's how we first came across. But I would love to pick your brains a little bit, to take it back a little bit. Our audience, so the audience that we have listening are speech pathologists, exercise physiologists, allied health professionals. We have some business owners, but we also have some students and those who are early on in their career. So I just wanted to take it back to some basic questions first, just so everybody can get their head around all the things that we're going to talk about. So I want to talk about anxiety, which is one of the areas that you mentioned you work with. So if a parent comes in and they say, oh, my child is particularly anxious or they've got anxiety, like I feel like sometimes it is a word that is thrown around a lot today. What is the actual definition of anxiety, or so that a child is diagnosed with anxiety? Like, yeah.
So there's a lot of different anxiety disorders, but for a kid to get diagnosed, it really has to be something that is interfering with their daily life, with their functioning consistently, and it feels above and beyond what is developmentally appropriate. So with SM, they're not speaking in an environment where they'd be expected to speak, and they start to pick up that, oh my goodness, all the other kids are off and playing, and my kid is not talking to me the minute we cross this threshold. For kids who just have a lot of worries in general, more generalized anxiety, it's just every change, every new thing, every new class they go to, their reaction tends to be much more extreme, and they're really dysregulated because the worry about, I don't want to try something new, this feels really hard, what if I don't like it? They tend to just kind of be a little more over the top. Separation anxiety is something that really has, I think, kind of increased since COVID, because we were together so much, and then there was so much fear about us being separated, and we have the social distancing, and then all of a sudden we're like, go play. The confusing message, and that could cause some distress when we're trying to get back to life as normal. Then social anxiety, it's just kids who are more on the periphery, really struggling to get in there in social interactions, and it's just hard for them, and it feels overwhelming. So we can have comorbidity across a lot of these anxiety disorders, but it really is for parents. I always trust parents' intuition, because to be able to, you know what it's like when they book a session and want to come talk to you, like clearly something's on their mind. They have this instinct. It's either it's been shared with them and they've had to think about it before they reach out, or they themselves are kind of alone thinking this is an issue, and other people are like, oh, just let it go. Oh, it's normal. And I always trust their instinct around it, because they're concerned, which means they've noticed that this seems to be bigger than it should be, and they're not quite sure how to manage it. So that's really what we're looking for, is to see how severe it is and how much it's interfering with their ability to be a kid. Because that's all we want, is for our kids to just play and be kids, and to be open to the world and open to learning. And if something is getting in the way consistently, that's too much for them, too much to have on their mind. It's making it too hard. So we can teach tools and intervene that'll, help them not have those worries. That's, one of our goals.
And when you said SM, so that's selective mutism. Right?
Yes.
Yeah. It's interesting, because as a speechy, like that's one of the conditions that we work with, and was trained about at uni. And so I thought selective mutism, everyone knew about it. But then I was speaking to another allied health professional, so not speech pathologist, the other day, and they were like, what's SM? And I'm like, oh my gosh. Okay. So can you just give us like a little bit more of an understanding about selective mutism and that?
Absolutely. So what's so fascinating about these kids is these kids speak totally fine at home. Like, they are chatty, they're bossy, they're directing everybody, they're speaking full sentences. There's no real language issue necessarily. And then when they're in situations where you'd expect them to speak outside the home and with people maybe they're not as familiar with, in school, around other kids, they stop speaking. And it's not that something happened. It's just, this is their body's response to the anxiety they're experiencing. And it's something that we see consistently in those situations. And it usually emerges around 3 years old. So 3 to 5. The research says it's usually more girls than boys, but we have a ton of boys who come in with it as well. So we have a pretty good number there. But it's where these kids are completely different personalities when they're comfortable. And then those families see this massive shift, and they don't expect to necessarily see it. So a lot of families, the kids will be in preschool, and they won't hear till parent-teacher conferences or halfway through the year that their 3-year-old hasn't said a word all year, And they wouldn't think that because their kid comes home and says, oh, we did this today. And they sing every song. They can tell you everyone's name. So the parents are like, oh, they're doing great. They're enjoying it. They go to school maybe happily every day. And then they're surprised when they hear that they're not saying anything. So that's really when we start to see it, is those early school days when they're unaccompanied, when they're unable to kind of get the words out. It's an inability basically, and they're not participating the way that they would like to, or the way that they could when they're comfortable in different situations.
And that must be such an incredibly lost or frustrating experience for the child, if they're wanting to participate and wanting and understanding everything. It's different if they've got language difficulties, where they might not actually be understanding, or they might not have the expressive language. But if everything is sort of there, that must be extremely, would it be frustrating for a child?
I mean, I would think it would be frustrating. The reason I was drawn to it is I was a very chatty kid. I was the one who was like, you need to stop talking in class. And I was like, I don't even know how I could go a whole year and not say anything the whole day when they speak. So that's why I was really drawn to it. So I was like, this is just incredible to me, that your anxiety could be that high that you're maybe not using the bathroom, you're not drinking water even, you're not eating, you're not playing. And, kids are supposed to do that. So I would imagine it's frustrating. Sometimes it's frustrating because they don't know what to do. And then what actually happens is they're missing so many opportunities to practice and play and do all the things you're supposed to do in preschool because they're not engaging typically. So then, obviously their social skills can be really impacted because they're not learning how to navigate those situations. They're not learning how to advocate for themselves and raise their hand. They're not saying, do you want to play this game with me? These are all important skills that we're teaching these kids at this age, and they're not getting that practice.
And so selective mutism and anxiety go hand in hand. Is it because
it's a type of anxiety disorder. It's classified under childhood anxiety disorders. Now, it wasn't though when we were first trained. It was kind of considered an other disorder, but they thought it was related to anxiety. Now, since 2013, that's when the new DSM really classified it underneath the childhood anxiety disorders. So that's what happened.
And with the childhood anxiety disorders, social anxiety is under there? Is that different to selective mutism or the same?
It is. So you can really differentiate the two. So we can have a kid who doesn't speak and in any environment outside the home, but loves participating non-verbally, is really popular with the friends, is in it and everything. So they're very social. They're just unable to speak. And then the socially anxious kid might have a harder time in those experiences. So they might not be participating. They might have more of that flat affect generally, rather than just when they're put on the spot and asked something. So you can have both, but we can also really delineate when a kid just has selective mutism. And as you can imagine, the kid with just SM responds usually really fast because they kind of just need the opening of like, okay, here's the space for what I need to do, and how people can talk to me so I can do it. Where the other kid might just take a bit longer to help them feel comfortable and to build those brave muscles.
And what is there a lot of other types under the childhood anxiety banner?
Yeah, so separation anxiety would be one, school refusal, kids who have specific phobias like difficulty sleeping alone at night, different fears like that. Those could all be things that they seem above and beyond typical development, which there's so much that is typical. If it just continues to go and the worries seem much bigger than they should be, we can see those in kids at a very young age.
Okay, that's interesting. There's a lot there, isn't there? Yeah. And so is there any reason why children develop anxiety? Obviously, it normally, specifically for social anxiety or selective mutism, you were saying that's sort of around 3. But is it from an experience that they've had, or?
Typically, no. It's very highly heritable. So it's within the family. So if you think about it, it's genetic kind of thing where it's in your family. And if you tend to be anxious as an individual, this is just how it's expressed perhaps in your kid. But then imagine you're the anxious parent, which I'd say most of us, especially with our first kids, are more anxious than we normally are. But if you already are prone to anxiety, there's just so much anxiety in the environment at that point because you're so anxious, and they're just kind of feeding off of each other. But really, it's just how it's expressed. There hasn't been anything that's been done. There's, typically nothing traumatic. I think that used to be a concern around it, that something happened. It's really more that, this is how their body, this is their stress response. In those situations, they are unable to speak. And the tendency for parents is to want to ask, why aren't you doing it? And the truth is, a 3-year-old can't really articulate the why behind it because they're not quite sure. It's just what the experience is. And the more you ask why, the more they're going to try really hard to come up with an answer to appease their parent. They want to try to, make them happy by giving them a reason. But the reasons might not necessarily be that. It might not, it could be so many things that are going through their little head. And, when they're 3, the insight isn't so consistent and reliable at that point about what they experience. It feels hard is really what it comes down to. It feels too hard for them to be able to engage that way. And it feels better by avoiding.
I think it can be difficult to have that emotional vocabulary so early on, particularly at 3. But I guess that's where parents then, if they're tuned in, can model different types of maybe emotional words or vocabulary type words and see if anything sticks, or, just in everyday conversation and things like that, just relating it to themselves, to model, like I felt this way, I felt a bit different types of emotions. Like I felt worried, or I felt really happy, or I just felt like overwhelmed, or I felt exuberant, different types of vocabulary around that would then maybe help them give voice to that potentially.
Absolutely. I mean, so with the book, our hope with the book is that it would have some of that language incorporated in it. So families who couldn't get to us would see the language modeled in the book. So then the kid would be hearing it while it's being read, and then the parents would be saying it, and then they would hopefully use it more often. So that was kind of the hope, is it embedded in it is some of the things that we do in treatment, and definitely the way we say certain things, so that we're helping the kid feel brave. We're talking about brave talking. We're talking about building their brave muscles. So it's little phrases like that we can hope the kid will hold on to and be able to use as their own self-talk ultimately.
How many children have, is there statistics on the prevalence of selective mutism? Is it a common condition with children? Obviously, your clinic has got a lot of children with that, but in the general population,
I think it's about 1% of the general population. But even with that, I would say the most seasoned teacher maybe has 1 to 2 kids in their whole career. So as much as, it's out there, again, just like you said, other professionals are like, what's that? It's not as well known until you know someone who has it. And then all of a sudden you're like, oh, I could see this, I could see that. Some of these kids are mislabeled as shy for a long time, but, with shyness, they warm up. Like shyness is a period of time of adjustment, and then they're able to be themselves. This is really much more chronic, where they are consistently not engaging the way that we would hope. They're not warming up. They're having a hard time, and they're really unable to participate in things the way that we want kids to. We want them to be at the birthday party running around. We want them to, play with other kids at the playground. We want them to be able to order ice cream for themselves and feel really excited. And these are things that are typically really hard for these kids.
Interesting. That's really interesting. And it's good to hear, because even as a parent, and then obviously as a therapist, it's like, where do you draw the line? Like you said, there is shyness, and it obviously is appropriate for children to have a little bit of wariness. You don't want your child to just go up to every stranger. I think it is a normal part of development, so that they recognize, oh, you're different. I don't know you. I'm going to have that appropriate social response. But then going, okay, well, what makes this then move into the realm of it's a little bit more difficult versus this is typical with development. And that's what we have to think about as therapists, as well as these children come into our rooms, if we're giving referrals on or trying to coach our parents.
Yeah. I think it's really about what's functional too. So, we want them to be able to function in an environment. We don't want kids to be overly friendly and to be walking up to strangers. That would be something we want to protect them against. But we do want them to be able to be in a doctor's office and say, this is what hurts, when they've broken their arm. And we don't want them to not cry out when they're in pain because they're so anxious. It's things like that, we want to teach our kids to advocate. And if they're unable to use language in those situations, it's going to be harder for them to advocate.
Do you think that I don't know if you know if there's any statistics that children that have speech and language difficulties, is there a correlation between anxiety there? Like it's higher or even selective mutism or anything like that?
So there's a higher rate of children who speak multiple languages, actually. So immigrant children have a higher rate of selective mutism, and that's probably related to them switching between the languages, not feeling as confident in every language. But you can't receive the diagnosis if you're uncomfortable with the language, because that wouldn't really be fair. So typically you'd be selectively mute across languages. For speech and language, if that better accounts for the reason why that they're not speaking, that would take up primary diagnosis. But we can have kids who do have some articulation issues and different things that will make it harder for them. These kids tend to be somewhat perfectionistic, that comes with kind of the anxiety. So, them not knowing how to say it right. What if I say it wrong? I don't know how to answer that. Those are things that where their anxiety, it might get them stuck. But what's crazy is once we treat some of these kids, we notice things like articulation issues where, that's not my area. And I'm like, but I get enough that you can go to a therapist now and you can speak to them. But we don't pick up on all of those when they're barely talking. So again, it's delaying that intervention. And we want kids to, really be able to correct those things that are correctable at those different time points.
It's interesting. So I've been a speech you for 15 years now, but I have had one child where the child came in for an assessment and they were querying, like the mum said to me, we're querying selective mutism. And then, they had a really big family and he was the youngest child. So they weren't sure whether it was something to do with those dynamics. And then, so I did my speech and language assessment and I actually uncovered that he had a very significant stutter and it was really impacting his ability to get any sort of words out, and he had to speak in a very structured way in order to be able to speak, and it was very rehearsed phrases. So once we were able to sort of dive into that with the stuttering, I was working with the site because we were querying what it was, but as we did the stuttering therapy and able to get some words out smoothly, then the psychologist was like, actually, no, it's not selective mutism. It was the stutter underlying it. So it was really interesting to see how we work together and how then they can go hand in hand. And I mean, with stuttering, there is a higher prevalence of social anxiety with that. And that's why the research used to say to us, wait, to treat stuttering and see if it's there for 4 to 6 months. Like that's when I was trained from uni 15 years ago. Now they're like, treat a child straight away because of the risk of the social anxiety and then the damaging effects that can have on a child long term.
Absolutely. And I would imagine the frustration of not being understood. And, when they're stammering and they're having trouble getting the words out, how that can then feed back to their frustration and their anxiety about possibly being made fun of, or, they're not understanding me, and having a negative self-concept around that. That's really, yes, that's good that you tag team that. And I love that you guys figured it out that way. You also could think if this had a big family, this child probably had to get stuff out quickly. And if he couldn't organize it fast, he was be able to effectively communicate because everybody else, he's the youngest. Things are going on really quickly around him. So it was just easier to be quiet than it would be.
Yeah. I was just like, oh my gosh, there's so much going on here. Okay, let's break down the layers here.
Yeah, the team approach is so helpful in those situations. So that's what's so great. And we've really started to train so many more speech therapists because you guys typically are the first go-to for a lot of these early childhood disorders. And what you guys do is incredible. I feel like, you guys create speech out of, children who are really struggling. I'm dealing with kids who already talk. Like I'm just trying to reduce the anxiety, but like they already know how to do that. It's very different that way. But we realized that, really training and, there's a way to get certified now in terms of how to treat selective mutism has been so helpful because you guys are the first touch point and people are more open to going to a speech therapist than sometimes going to a psychologist. There's this fear around, what does this mean? And we're trying to change that in general. But, I think for parents, you hear psychologist, you're like, is something wrong with my kid? Where speech therapists, you're like, oh, we're boosting something, we're things. It's just different.
Yeah, I often have those discussions with other allied health providers because the speech is something that parents seem to notice first. And the lack of, and it's easy to compare it to with peers, like, or babies, like, if you're first time mum and you're not really sure, that's sort of what they're looking at first in terms of I think apart from walking, and those bigger gross motor milestones. So we then tend to have to be that first case manager type person and then refer out and things like that. I guess, and because of that, that's why then it's important that as therapists, we're so informed about what signs to look for and to how to refer on, and how can we help in our sessions. If we did have a child come in and we were questioning anxiety, or if they needed a referral to a psychologist, obviously we've talked about, if things or anxiety is impacting them functionally and to a larger extent, what could we do in our sessions to help that? Or even if they're seeing a psychologist at the same time, is there anything practical that we can as therapists do?
So I think when they're speaking, I think the way you guys typically do practice with kids anyway, there's a lot of modeling that happens and reflecting. So when they are speaking in the room, once they're comfortable, doing that at a really high rate could be really helpful. And, with SM kids in particular, they tend to be really sensitive to feedback. So how things are presented, perceiving things as criticism instead of correction. So even how it's modeled, you can model the correct way to say it, and then they could do it rather than, it's not like that, or you said it wrong. So it's little nuances like that in terms of how we interact, so that we're helping them to feel comfortable. We're helping them to kind of do it at a higher rate, but we're being really sensitive on our feedback on how they're doing it, how much effort they're putting towards it, how much we like what they're doing and what a good job they're doing. So they're feeling braver as they're doing it, which will then make them practice more and more and feel more comfortable. I know you guys bring in a lot of play. That's what we do with the kids too. Any therapy with kids has play in it, but we talk about the elephant in the room, like, oh, we're practicing brave talking. So, and then we make rules around how we can integrate more talking into things with little phrases and different things as well. But again, it really depends on the speed at which we can do it on the kid and where they're at. So this is not something you can be like, session 1, I'm doing this. It's really about meeting them where they are and then helping them make progress at their rate. Still pushing for change constantly, but at a rate that they're comfortable with, so we're not overwhelming them.
Yeah, so being like very flexible with your sessions.
Absolutely. I mean, you guys are flexible too. You have to pivot, and if they get bored, you have to fill in something else. I mean, it's definitely a show, I think, sometimes, especially with the little ones, where you have so many different tools you use. We do the same thing. The goal with, I think, both of our therapies is, how can we make this fun? So, because if it feels like work, they're not going to want to be there. They're not going to want to do it. But if we can make it fun and still be doing the work, we can see that improvement. We can see that improvement happen over time.
Yeah. And so with them, like, I think what you were mentioning there, like, it would be really important for us to consider our feedback, right? Like, if we're saying brave, well, could we use like words like that in our therapy session? Like, that was so brave.
Yeah. Well, so we're even more specific, great brave talking, because we want to talk about what's brave. It was really great saying that and working on the ending of how you said that. I liked how you said the rural sound or whatever. Again, I don't know. I don't know exactly what to do, but whatever it is, giving that specific praise, or, oh, that was the best, like track talking that time. I heard how smooth that was. So they're getting that feedback. So then they notice the difference, and then they're going to notice when they're doing it again. So it becomes a positive for them in general. But yeah, you guys can absolutely do that. And the reflections, I know you guys already do. In general, speech therapists are amazing at reflections. That's a really important skill, to let them know they're being heard and that we're giving that feedback on, that we've heard it and we've approved of it, basically.
And the little thought I had come to mind, because with feedback, like, it's very tempting. I notice in myself with my kids at home and also other people, it's sometimes tempting in your feedback just innocently to be like, oh, that's perfect. Do you know that? Like, yeah. And so
I love that you just said that. That is like my word, or I'm like, strike it from your vocabulary.
Yes.
General, because it's just this unattainable goal. And that's not what we want modeled for our kids in
Mm,
general. And again, I deal with anxious kids. Anxious kids are always wanting to get it exactly right. So
yes.
my goal is to help to tolerate them not getting it right, tolerate that when they fall down, or tolerate when it doesn't look the way they wanted, and then being able to move on. And, it's the same with how they're spelling, how they're speaking, anything, how they're playing a game. If they win or they lose, like we're really trying to incorporate a lot of that. So you and I are definitely the same page with that with family. It's like, try your best to take that word out
Yeah,
of
you
the
take it out.
vocabulary.
And you sort of are more, like we said, you're commenting on their effort, you're commenting on the result, like, brave talking, or if you're doing stuttering therapy, you'd say good smooth talking, that kind of thing. It's really interesting because it's just something that we can automatically do as therapists, to be like, oh, that's perfect. And it was really interesting the other day with my daughter Evie, because she does have perfectionism tendencies, and I do try very consciously not to say it, but obviously has slipped out at some times. And she said to me the other day, she was drawing, and I said to her, oh, that's fantastic. Like, I love that drawing. Like, whatever she did, I said, oh, I like that you traced it or something. And she said, no, mummy, it's not perfect. And so again, that was a good wake up call for me, because I said to her, oh, look, it doesn't discount anything. And then you go into major, like, let's diffuse that comment and the situation in the moment. But it's a good example of how children internalize the feedback that you're giving them, and that then becomes their own thought. Whereas if that wasn't modeled to her, that wouldn't be her thought potentially.
Potentially, yeah, that is definitely something. So there's a great book called The Beautiful Oops, which I love. And the whole story of this little board book is how something that doesn't seem right or seems like broken can actually turn into something amazing. And it has like a coffee stain and how they make it into some drawing, or like a jagged page and they make it into like a crocodile. It's just such a nice way to help kids be flexible with that, because we can see it in little kids. Like, they'll see a mess on their paper and they'll be like scrunch it up and wanting to toss it in the garbage.
She does
And
that all
we
the
wanted
time.
to, and what we said, nope, this is the paper we're using, and we help them tolerate that it's imperfect and that they can still use it, and they can still make something on it, and it can still be fantastic because of the work they put on it. But you see little things like that, and it's always thinking about, how can I challenge them to tolerate it to some degree without them being so distressed by it, right? But like, we don't want them to waste the paper necessarily, or we want them to be able to flip it on the other side. And this is quite common with little kids when they have great ideas in their head, but their hands can't execute those ideas just yet. And there is this frustration that comes along with that. So it's helping them to want to work to improve, but not aiming for perfection, aiming for like getting better and having that attitude of that growth mindset towards anything and everything they learn.
And that's so important, because I think that's then what shapes them as adults, right? And that's the end goal with your children, is that you're thinking about how can they be the best adults that they can be to contribute to the world and live their purpose. And I think it's a real skill to be able to tolerate the imperfect. And a lot of adults struggle with that.
We do. And I think it's so, and tolerating our children's distress when things don't go just right. So sometimes that's hard for us too, by how it's perceived, or what are they doing, or so, and just seeing like they're a kid and they will do that sometimes. And the calmer we are in these situations, and I will be honest, I'm human, so I'm not always calm, but the calmer we are, the easier these things are going to be, the quicker they're going to recover. And the thing with clinicians is, we do make tons of mistakes, but we notice and we pivot, and then we're able to repair faster because we realize the misstep in that. So it's just thinking about how we can really support our kids to be able to tolerate changes, tolerate when things don't go their way, or tolerate when they're feeling overwhelmed in a calm and loving way.
Yeah, and creating that safe space for learning, because then when they're coming into the therapy sessions, that's then the goal as well, for them to be learning and improving on their skills.
Yep.
If we have a parent coming in and the parent would appear to be highly anxious, how can we best support them? Like, obviously we can say, well, I mean, obviously when they come into speech therapy, we're sort of dealing with the child. And so we might say, the child needs a referral, but if we are feeling like the parent is very anxious, is there any strategies that we can work with them apart from a referral?
I think, what's great a lot of times for, different types of clinicians, for speech therapists or OTs or PTs, they'll have the parents sometimes join the session. And
Yeah.
that's really the opportunity to, one, be modeling what you're doing and explaining the why behind it, which can help to lower that anxiety. Because there's a lot of guilt and shame, like, did I not intervene soon enough? Did I do this? Like, how am I going to fix this? Like, they're worrying about everything. So the more that we can kind of empower them with, if you practice this at home, we'll get to see this positive change, and helping them to actually be able to do it. And also helping them understand your kids can be more resistant to doing this with you than they are with me. So letting them kind of have that permission to, like, make it fun or not to do it too much or not too intensely, I think will really help them. Letting them know that you are with them on this journey. I think that's what's so special about what we all get to do as clinicians, is that we get to join with these families, and they know that we're part of their support circle now, for looking out for the kid with all the best interests for this child in mind. And for that, to a parent, can be such a relief to know they have someone they can ask questions to, they can reach out to. And we are kind of giving a good prognosis about, if we work on this like this, we can expect this change over time. Again, it'll be at the rate that they go, but this is our hope. This is what we're looking to achieve, and then we'll work on this. So they just need to be brought into the discussion, and then also relieved of some of that guilt, but also empowered with some of the skills, because they want to know what to do. And they look to us to be like, fix it.
Yeah, exactly. Yes.
So the more we can help them to be that active agent, the more likely they're going to be like, I can do this. I am helping them do this. Oh, I'm noticing the change because I've been doing what you said. And then that gives them that positive feedback too, and that feeling of that they can be really effective with their child too.
Yeah, and I think that's most of our roles as therapists, is to work with the parent as much as it is to work with the child. But because if you can be doing the best work with the child, but if the parent isn't on board, then yeah, not much is
But
going
they're
to.
not practicing. Like, we only have
Yeah.
1 hour a week if we're lucky, because, like,
Yeah.
we are busy, we have full caseloads. And
Yeah.
this is why we really pivoted how we worked with a lot of children, is to say, if we really train the parents, which it is a bit slower than when we could grab them, but overall the progress will be faster. If we can train them and support them and coach them in how to work with their kid, they're going to have that opportunity way more than we would ever have in a week. And we've seen such huge changes and really improve relationships by helping the parent understand what the struggle is and how to help support it. And also when to, not push for the day too, so they can really start to figure it out.
Yeah, I think that's the battle as a parent. And I guess as a therapist, it's like, how far do we push? How much do we push the child, or how much do we not push?
Yeah.
And I would think the answer to that is it's very individual with the child, and having a very deep sense of the child and what they can handle, what they can't handle.
Definitely. And I feel like, us as professionals, we have that sense already. Like, we can read the situation and be like, yep, this is good for today. Or let me go for a little extra. And if it doesn't go well, we can also backtrack and fix. So I think, again, giving the parents permission to that too, to, like, if it's feeling too hard, let's just cut it for today. And then we'll try again tomorrow, knowing that all is not lost if it doesn't go, perfectly well, really reinforcing to them, progress is not linear. Like, it takes time. These are little human beings that we're dealing with here, and there's a lot going on. So as much as we want it fixed, it takes time, and it's a process.
Yes. And that's coming back to being the flexible clinician and being okay with our expectations and what we set for ourselves clinically versus what's realistic, looking at the research and then going, what's our clinical experience, and then bringing into a holistic picture with what our parents and family and cultural background and all that, how that impacts on what we're delivering with our services. If I have clinicians that are wanting to get more information about anxiety or selective mutism, it's not, like you said, clinicians might only have 1 or 2 in their caseloads or over their careers. But if they do have children that they want to get more information about, do you have recommended resources that people can go to or sites or whatnot?
Absolutely. So we have a website called Brave Mighty Minds, and it's literally a platform that's creating resources for, different clinicians, for educators, and for parents. And we have a free webinar coming up for teachers. We're trying to kind of provide resources that are needed to educate more people on selective mutism and just childhood anxiety in general. And we'll be expanding that as we go. For selective mutism in particular, too, though, Selective Mutism Association in America has great resources, and they even have called SM University is what it's called, and you can go and learn all these skills basically. So it's a nice entry into understanding what we do and how to do it. Really early skills, kind of just very lightly kind of going over, but that's a great place to start too. We also are going to be doing things like having calls monthly so that providers can come and ask us things after we've trained them in the skills, even remotely. So if they have questions, we can help to guide them. Because what's so great is, we learn some of these things. We're like, what if it doesn't work? Like, what if I'm stuck right now? So to be able to have that point of being able to ask questions on a monthly basis of like, I'm not quite sure how to do this is really helpful. So we're all about, again, extending the reach of helping as many kids as possible and not feeling like there's only a few people who can do this. Like everybody can do this if we're trained and open-minded about it, and we can integrate it together. And it's, we need to collaborate with each other because, we all have different specialties that really do help kids function best overall.
Yeah. And I think it's normal that you've always got questions and going, what happens next? Because you're dealing with people, you're dealing with emotions. And like you said, learning's not linear and neither is development. It feels like you go 2 steps forward, 1 step back with behavior and things like that. So that's just the nature and the reality of working with people, isn't it? And little people, like you said. If people want to get more information or follow along with you, where can they find you?
So they can find me on bravemightyminds.com or on Instagram at Dr. Melissa Giglio, or again, Bravery Grows has its own Instagram too. So all of those are good ways that all paths will kind of lead to Brave Mighty Minds. But we do run intensive camps here also twice a year for kids who have selective mutism. And so we have had families fly in from different countries for that. And that's really cool because we do about 20 hours of therapy over 5 days in a group format with one-to-one with clinicians. So that's a really great resource for families who are having that struggle. But we've also had clinicians fly over to, sit and do the work with us for a week so they can kind of see how to do it and through the process and the change that can happen in a week. So we're always open to, again, spreading the word, training more people. We'd love to even come to Australia someday and help run a camp there because, it's really hard to coordinate. It takes time, but they're so effective. So being able to kind of make sure that more people are doing it in a way that we know is evidence-based is really helpful.
Yeah, well, we would love that. Come to Australia.
Anytime. I love Australia.
Yeah. There's so much out there, I guess, that information that people can get. But I think if you're going to get mentoring with someone, it's better with someone who's a bit more niched, like Dr. Melissa is saying. It can be tempting to go to someone who might work with everything, but I find the best information that you get is when you go with someone and they're like, I just work on this one thing, or I just work on these 2 things, because you get a really, really solid mentoring experience like Dr. Melissa just outlined. Thank you so much for your time today and for your expertise and for your knowledge. I think this is going to be really, really helpful for lots of our clinicians all over the world. We have listeners from all over the world. And like Dr. Melissa said, if you want to get in contact, there's lots of different platforms and channels. If you've got children that you're wanting to get clinical advice from as well, like clinical advice for with these types of conditions, now you have a contact, you know where to go. And looking forward to, one day meeting you in person and you coming to Australia and connecting.
Absolutely. Yes. We will, and we'll share any new books that are coming out too. And hopefully,
yes.
So yes, no, this has been so wonderful. We love that the outreach is going to Australia. We want to connect with as many people as possible to get the word out and help people.